strong support and showing of Lee's specialty clinic. It's very, very important. It's very, very important to the General Assembly that you all make sure that we try to get the funding for you all, and that's a very strong priority for us. With that, I just want to do a couple things. One, we do have overflow rooms. I think, as Ms. Bates mentioned, 149, 169, 179, and 129. I'm sorry, what?
171.
171. So I just hereby call the fifth Medicaid Oversight Board meeting of 2026 to order. I would like to welcome our newest member, Representative Wilner, who replaces Representative Marsden. Thank you very much for volunteering, showing up, and giving your background. You're going to be a great asset to the board. So thank you very much, Representative. Elizabeth, would you mind calling the roll, please? Thank you, ma'am.
Senator Byrd, Senator Carroll, Senator Meredith,
Present.
Senator Richardson,
Here.
Representative Heverin,
Here.
Representative Mosier, Representative Williams,
Here.
Representative Wilner,
Here.
Vicki Yates-Glisson, Holly Harris, Joe Petrie,
Here.
Steve Shannon,
Here.
Senator Douglas,
Present.
Senator McDaniel, Representative Bowling,
Here.
Representative Petrie,
Here.
William Baker,
Here.
Auditor Allison Ball,
Here.
John Hicks, Commissioner Lisa Lee, Sheila Schuster,
Here.
Secretary Stephen Stack,
Here.
Tom Stevens,
Here.
Co-Chair Fleming,
Present.
Co-Chair Adams.
Here.
Thank you, Elizabeth. And I believe we're deemed ready to go since we have a quorum. I wanted to remind everybody that please remember to silence your phone just like I did. Also, no signs in the committee room. We will be administering the oaths to all presenters to the board, and there is a sign-up sheet. I think we've got that. We've already taken that up. I'm sorry. Okay, the sign-up sheet is still back there, and at the end of our board meeting, we'll allow some time in order to have some public comments. Our first order of business, members, I'd like to have all board members to make sure they got their meeting minutes of the last two meetings, and I want to make sure that we go through the proper motions to get this approved. So do I have a motion to approve the minutes from March 9th? We have a motion. Is there a second?
Second.
We have a second. All in favor say aye.
Aye.
All opposed by like sign. Very good. Thank you all. And for the March 16th minutes, do I have a motion for the approve the minutes of March 16th, 2026?
So moved.
We have a motion. Is there a second? Second. And we have a second. All in favor say aye.
Aye.
Very good. That's approved. So thank you all very much. Okay, next on our agenda, we'll have a presentation from the Department of Medicaid Services on statutory reports and data requests. DMS was asked to present on 5 reports, which include quarterly budget reports, quarterly MCO reports, provider tax report, enrollee demographic report, and behavioral health and substance use disorder utilization report. There's a lot of reports, there's a lot of information, and I believe there's so much information. We provided that electronically, so hopefully y'all have got that access either electronically or you have it on a piece of paper. So with that, we have, let's see, okay, good, very good. I was going to have y'all come up. The commissioner and the chief financial officer will make their presentations, and I just wanted to ask you to raise your right hands, please. Thank you. Do you swear to affirm to tell the truth, the whole truth, and nothing but the truth? Very good. Thank you very much, and you have the floor. Y'all need some help? Okay.
Good afternoon, and thank you, Chairman Fleming and Chairwoman Rocky Adams. We appreciate you giving us the opportunity to come and share with you all. My name is Steve Bechtel. I'm the Chief Financial Officer for the Department of Medicaid.
I'm Lisa Lee. Thanks. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services, and I would really like to echo the sentiment expressed at the front of this meeting and thank everyone for being here for their advocacy for the Lee Clinic and the Medicaid program. Their attendance here definitely shows how important these programs are to all of those that we serve. Thank you for being here.
So as you said, we were asked to come over and answer some questions about these reports, to be ready to answer questions. We're not sure exactly what your questions are, but I did provide some context, some slide information, so that you can help you all understand. The first one is the quarterly budget analysis report. We refer to this as LRC report, which is the Legislative Review Committee report. We have provided this. This is a report that's been provided to the LRC quarterly since July of 2000. So it's not a new report. It's just has evolved. Just like Medicaid has evolved, so has this report. This report has been changed recently to include other items, and I listed those there for you. But what I wanted to do is give you a context because there's some misunderstandings, misrepresentations of this report. It's got 8 worksheets. And I've given you a detail of what each worksheet shows, all right? The budget analysis, what a lot of people do is they'll go to the very first tab and they'll look at it and they'll say, hey, this is how much Medicaid fee-for-service spent on a certain service like dental or vision or hearing or even waivers. But what that does is that's just the Medicaid traditional population at the top on that first slide. That first tab, because you have to go down to look at the expansion and the CHIP is all aggregated on one line on that first tab. If you want to see the total spend, you need to go to the 4th tab, which is summary by category service. And that will give you the total spend for each category service across the populations. The map, those slides, those worksheets there at the bottom, tab 5, 6, 7, and 8 of that worksheet, that goes into traditional Medicaid, the expansion Medicaid, and the 2 CHIP programs. And that details that out by the penny. And those are all reconciled each quarter to what we spend in our EMARS accounts. So just some highlight. I wanted to give you some key observations. The first 3 quarters of this fiscal year compared to the first 3 quarters of last fiscal year. You can see a lot of these are, what I'm showing you here is mainly traditional Medicaid. I did use it off the category service summary tab. But when I compare those 3 quarters to the first 3 quarters of last year, you can see across the waivers we have spent $191 million more in this fiscal year than we did last fiscal year. Across other items such as nursing facilities, certified community behavioral health centers, the FQHCs, the federally qualified health centers, you can see that a lot of those are like $250 million more. And so in combination of those services, it's been about $450 million in additional funding that what we've paid this year over last year. And this is just fee-for-service spend. So I will point out that the bottom line, Medicare Part D premiums, we include the Part A, Part B, and Part D premium deductibles, increases in those. Those Part D premiums are 100% state funds. So to estimate the total state fund increase for the first 3 quarters over the first 3 quarters of last year, you can see it's about $140 million in state funds. Then the next report you all asked me to talk about was the MCO quarterly report. It's kind of a similar report. It's the same type of report that I just gave to you just a minute ago over the LRC, but what you all have asked me or what was instructed us to do was to pull in the data from the managed care organizations by category service and report that out aggregately to you all. You can see the things I want to point out on this, the first 3 quarters of fiscal year 26. You can see there's 3 components that makes up about 2/3 of what the MCOs have paid out. And that is pharmacy. Pharmacy is by far the largest of the 3. And then you have inpatient hospital and outpatient hospital. But those 3 items alone make up 66% of what has been paid out by the managed care organization so far this fiscal year. The third report is the healthcare provider tax report and assessment report. This is in 2 sections. The top section is what is collected by Department of Revenue. These are your normal provider taxes that has been implemented over the years. And you have the statutes there referenced so that you can see which ones they are. But then the ones at the bottom is collected by DMS. And those are associated with IGTs and the rate and the tax associated with the directed payments. Mainly, those are the directed payments, state tax dollars. The only 2 things down there that's not related to directed payment is the Kentucky Access Funds, which is not transferred until after the end of the year of what is remaining in the Kentucky Access dollars will be transferred to Medicaid benefits. So you can see that is 0 right now because that won't be done until probably period 13. And then the managed care 1% assessment, which we collect every year in March from all the MCOs. And you can see that has been referenced there. What we've provided, what this report asked us to do is what is the federal match assigned with these state tax dollars and how much was the total. And so we have provided that for you there at the right.
The next report that you all had requested, you're finished with tax, right? Yeah. The next report you all had requested was the enrollee demographic report. That report is in your packet, and I believe that it has also been posted online. That report contains the number of individuals enrolled by eligibility category. It also details employment status, race, ethnicity, and we do not have a slide on that, but happy to answer any questions on that demographic report that is contained in your packet. The next report that you asked us for was the Behavioral Health Substance Use Disorder Utilization Report. That is an annual report. Our first report will be fiscal year 2026. Fiscal year 2026 ends in just a few short days, and as soon as the fiscal year ends, we will develop that Behavioral Health Substance Use Disorder Report for your all's review.
And then the last is, it's not really a report, but we were required by legislation to set up a Medicaid pharmaceutical rebate fund on which all the state dollars of the rebates are deposited into. And you can see we've set up that account, and it is account 13VG, V as in Victor, G as in Gary. But those are, that's the account that's been set up to house the state funds of these dollars. The federal dollars are still offset of expenditures. So it's kind of complicated because the federal share is still an offset of expenditure, while the state share is operated as a revenue. So that, in its sense, if you recall, I did testify several times that was going to raise our budget. And it's not, so to speak, that it's the same or more dollars. It's more of a appropriation increase because we had to have the restricted fund appropriations to spend those dollars. So that has raised our budget by $300 million. You can see as of today, this is, at the time I did this slide, I gave you the updated amount of our drug rebate, what we've collected in federal and state dollars. And what we do with those state dollars when we receive them, we deposit them at the current FMAP at the time we receive them. But then at the end of each quarter, our PBM has to look at what time period those were for and what they were actually for. Were they for an expansion member? Were they for a CHIP member? Was it for a traditional Medicaid? And so then we have to do what we call JVs, journal vouchers in the system, to make sure that those correct federal dollars get sent back to the federal government. And so we do that at the end of each quarter. It's about 45 to 50 million as those adjustments. And so what I'm showing you here is minus that last adjustment so far. What you'll see is that money will go from the state over to the federal. It's just back and forth. But it won't change the total dollars. It'll change the federal and the state share. So We will still be close. We still have a few extra days, so we should get some collections hopefully the next few days from providers. From the drug rebates, and so we hope to have this finalized through period 13 and have that finalized for you all. But it should be close to 300 million, if not just slightly shy of 300 million. That is what I came here to present, but now I'm able to answer any questions that, like I said at the beginning, I'm not sure what questions you all may have had about these reports, but I'll be glad to answer any questions you may want to have.
Are there any questions from the members? Go ahead, Ms. Glisson. Make sure your microphone is on and it's close to you.
Thank you.
Thank you.
Thank you for your report. I appreciate it very much. Quick question. When I was going through all of these numbers, I had a question about whether the total spend, you mentioned that particularly on number 3, the slide 3, on the quarterly budget analysis, that included the total spend. Does that include, I wasn't sure, both the administrative cost to the state as well as the benefit cost? Because I think generally there's an administrative cost of like, we get reimbursed a match of 50% with the benefit is somewhere between 70 on up. So I wasn't quite sure.
What I showed you on slide 3, if you're referring to the one that says key observations,
Yes.
that does not include the admin. That is just the benefits portion.
Okay.
The administrative, though, there is a line on the I call it the LRC report, but it's the quarterly budget analysis report. There is a line at the bottom that shows the administrative fees.
So on that report that you gave it, maybe I missed that line. Okay.
Yeah.
So it's on one of those slides. I need to go back.
It's not
and
on
look.
one of these slides. No, ma'am.
Okay, I couldn't find it.
Yeah, it is on the report that we submit to LRC quarterly.
Okay.
So there's a spreadsheet and a PDF format of these reports that you all can see, but it is on that first tab at the bottom.
Yeah, it's such an important number because
Yep.
we have to end up paying 50% of those
Well,
administrative costs.
It's not always 50%.
Okay.
There are sometimes it's 90-10. It depends on what it's being used for. If it's
Right.
for
A newly
systematic
eligible
IT,
rather than a traditional.
Correct.
Gotcha.
And then there is some that is 75-25 if it's based off professionals and versus non-professional.
Okay.
So like for nurses and things, nurse consultants, we get 75-25 on those.
Oh, okay.
Yeah.
But I wanted to make sure that we knew that this number is only for the benefit piece and
Yes.
not the admin piece, which has a considerable impact on the budget.
Correct.
Okay.
Any other questions? Mr.
Can I
Shannon?
ask one more?
If you don't mind, ma'am, let me go to him and then
No,
I'll come
that's
back to
fine.
you. Is okay?
Oh, y'all, I'm over here. CCBHC, Certified Clinical Behavioral Clinic, it's been my topic for the last year. The spend went up. Have you looked at how CMHC, Community Mental Health Center spend decreased as CCBHC expanded?
We can take a look at that, but what I was here to prepare,
Yeah.
what I showed you today
I
was
just think
just
it's
the
important to
aggregate
realize,
number. Yeah.
they migrate from one to the other,
Correct.
so it may very well drop. And the expansion of 6 additional ones will be reflected in this fiscal year as well
Correct.
as an increased spend.
Go ahead.
Yep, go ahead. Thank you.
Not just another quick couple of questions on the provider tax and assessment report.
Mm-hmm.
Have you begun, or do you have any idea what the impact is going to be on the new CMS proposed rule on state-directed payments and other supplemental kinds of payments? What impact that may have on this slide? I know that there's an initial report that's going to be due in January 2027.
Mm-hmm.
So I didn't know if you had begun putting that together, and is there anything you can share on that?
So if you're talking about
update it.
if you're talking about the 10% reductions, that's in House Resolution 1, the 10% reduction year over year from our grandfathered amount on those directed payments. When you see those go down, so will the provider tax. Because the provider tax that we submit on those preprints is just for to cover the state share of those payments.
Well, I was really referring to the new CMS proposed rule that just came out maybe on May 20th.
Oh, yeah. Yeah, well, the way that changes, it doesn't change much. I mean, we are changing the 10% reduction.
Right.
But what we are allowed to do is we still are allowed to have separate payment terms, which I think is excellent, because what they wanted us to do, a separate payment term, is being able to pay that outside of the managed care capitation rate. That's more transparent, in my opinion, than to build it into a capitation rate and get buried into a capitation rate. But House Resolution 1 said that was going to eliminate separate payment terms. We had to build it into and make them risk. We had to build it into the capitated rate starting in 28. However, the new proposed rule that's out there is allowing us to continue the separate payment terms through the time period of the grandfathering period, which means as that goes down to the Medicare levels, we can still keep it at separate payment term. However, once it gets to the Medicare level, we will have to build it into the capitation rate.
So then it probably doesn't, at this point, you're thinking that the impact to the bottom line is minimal on
Correct.
what the changes are from the federal level, the new CMS proposed rule. I just wanted to make sure we were aware of what
I
impact
wouldn't use the term minimal. It's
Well,
going
I
to be
didn't
a
think so. It
substantial
seemed like it
amount
was
of
gonna be pretty
decrease
impactful,
for
so-
our providers, but not, from an administrative perspective, it's going to be minimal. But from a provider, if I'm looking at it from a provider lens, it's going to be substantial.
Yes, that's what I would think too.
Yeah.
And it might be, if you get any numbers on that, I think that would be very helpful, just to help the providers get prepared for this and what the impact's going to be.
Yeah, we have been sharing information with the Kentucky Hospital Association
Okay.
with that.
Good. And one other last request is that on the MCO quarterly report, can you share your recoupments? And I think you all get a number on recoupments. Could you share that and add that sometime or another to that report? That would be helpful.
Recoupments, define recoupments, please, because
well-
that means several things.
Well, I think if you even break it down, I remember that there was usually a number that said we've recouped this many dollars from providers.
Oh, okay.
Yeah.
All right.
Thank you.
Thank you.
You're welcome. I just want to ask a question. Under the citizenship status, is this? I've got it goes from, and I'm just using it from A and it goes to P. Is there more information? I don't know if I did not copy this correctly.
Yeah, there should be a total page at the end of that. It looks like the total is missing when you look at the citizenship status, and it goes over to the back page. There should be another page with an actual total number for all of those in here. So there is a little bit of information missing from that page.
Okay, it's not in this packet that I have.
I believe it is in the report that was posted online. It seems like maybe it was just the last page. It was probably just a couple of rows, may have been either cut off in printing.
Okay. I know there's like one category, and I don't have that other sheet that concludes the P through Z categories. What is other? Can you give me a definition of that?
Yeah, that's a really good question. I actually had that question myself when I reviewed the report. So we are looking with our eligibility team to see exactly what that is. And I think the other one that you're referencing is unspecified. So those two, yes, we are looking into that with our eligibility system.
Right. If my memory serves me correctly, when I looked at the one last time, that there was that a category for being a tourist. Mm-hmm. And I want to say like about a dozen or so. How does that work? How does that become a category in terms of citizenship on getting coverage?
There are certain eligibility categories for tourists that would apply for or would qualify for Medicaid, but I'll take that back and get some more information specifically on that category and get you some responses on the other and the unspecified.
Okay, and one last question, Commissioner. Can you assign a cost to this? Looking at other, using an example, we got 2,100. So what's the cost of that?
Yeah, so you want to know the spend on them for the report Yes, we can go back and pull claim information for those individuals that are in that specific category.
Okay, so you don't know what the average cost is for that? For
No.
the unspecified or the other? and so
No,
forth?
I don't have a report with it broken down
Okay.
by citizenship, spend by citizenship.
Okay. Okay. All righty. Any other questions? Chairman Meredith, go right ahead.
Just a brief one, Mr. Chair.
Who does? Alice, okay.
Where would we find medical loss ratio?
I'm sorry.
Where would we find the medical loss ratio?
That is, we have that as an individual report. We can provide that information.
I'd like to see that if possible. Thank you.
Auditor Ball, you have the floor.
Thank you very much. Our work for the past 2.5 years, we've discovered several wasteful expenditures. The $836 million of capitation, concurrent capitation payments in Medicaid. This is a high-level document, so I don't expect that you address that specifically in a document like this. But I'd like to know, have you made changes to make sure we're capturing that money for the future? Could that money be used to offset some of the proposed cuts that I know these people are interested in here today? We also found in our SWAC from this year and from last year too, we found double Social Security, more than one person using the same Social Security number. We made recommendations to change that. I know this cabinet agreed with those findings, as well as some ineligible immigrants who were on there and some people who were dead who were on there. We had I know responses from you all saying that you agreed with those findings. So I would like to know, have you made a plan to make sure we're not wasting those dollars in the future? And could those dollars be used to offset any proposed cuts?
Well, thank you for that question. We definitely focus on fraud, waste, and abuse in the Medicaid program. It is a massive program. And to respond to your $800 million question, that report and the $800 million is not actually factual because it did not break out the number of individuals who were both enrolled in Kentucky and in another Medicaid program at the same time. So we cannot go back and determine where those individuals should have actually been, and that report was during the COVID period also. We are making changes. We are looking at every one of our eligibility systems. As you know, we are getting ready to make massive changes related to community engagement requirements, so that will impact our eligibility system, but we are doing our due diligence to make sure that individuals who qualify for the program are enrolled in the program.
Thank you. We also, in our ombudsman report, we listed a lot of error rates, and some of them were quite high. I'm going to point them out for just a moment. And I want to make sure that you're aware the 6.87 error rate for SNAP benefits, 3% error rate for MAGI Medicaid programs, and 42% for long-term care Medicaid program, and 25.56% for the Medicare Savings Program, 11.48% for KTAP and TANF. Some of those are high error rates, and I want to make sure that there's efforts being taken to address those high error rates, because those are dollars that I would think would be useful in situations like this.
I can't address the SNAP error rates or any other, but the Medicaid adjusted gross income error rates of 3%, that is out of over 1.4 million individuals enrolled in the Medicaid program. I'm not sure where the long-term care error rate is coming from, but we do go through audits ever so often. It's called the PERM audits, the Payment Error Rate Measurement audits that CMS conducted. And the numbers that I look at with their PERM audits are nowhere near the number that you have quoted here. But again, I have no idea where the long-term care error rates are coming from and who's conducting those studies.
We are. And we've been in communications with your cabinet. That's one of the things that the Ombud does. And we have an entire division that's focused on error rates that works actually quite nicely with you all collaboratively. So I just want to make sure that, and it sounds like it's good we're having this discussion today, that rises to your level, because those error rates are something that I think can be fixed, and then that frees up other dollars.
Yeah, and I'd be really curious to look at some of the long-term care eligibility rates. And I believe, though, when you work with the cabinets with their eligibility determination workers, and I'm glad that process is going really well. But I'd be curious to look at some of those long-term care error rates, because Medicaid long-term care is the most complex eligibility determination process, and sometimes those cases can take years to determine. And so I would be really interested in looking at some of those specific cases to see if there's something that we could do within the program to identify specifically what those cases were.
Is that all you have, Auditor, or do you have? If you have one more, I don't know, let me, Senator, did you have a question?
I'm just wondering if the auditor has that report available for us to review, because I have not seen that data prior to this meeting.
Go ahead.
If I may,
Go
Mr.
ahead.
Chairman.
And when was it presented to us?
Thank you for the question. We actually presented that, I believe it was to LRC, but not in a committee hearing. We published it, and it's an Ombud publication that it was the first one under my leadership. In fact, it's one of the first ones I think that's ever been done quite at that level. But it's on the website, and I'm happy to make it available to any of the committee members. But it's been publicly available probably for the last 2 months. In fact, when I testified in D.C. to Congress, we used that information as one of the bases that I talked about at that particular time. It's available, and I'm happy to make sure everybody's got a copy of it.
And
A
just-
follow-up, please. If there's this degree of discrepancy between information from different parts of our same state government, this is a problem that needs to be addressed and resolved. That's not okay. These are actual numbers. It's not made up. You can do it mathematically. So I'm upset to hear about this discrepancy. I'm upset that this data that you're talking about has not been directly presented. A 43% error rate. What did that have a financial impact?
I tell you what, Auditor
All
Barr,
right.
go ahead if you wish
Thank
to
you.
respond
Thank
to
you.
that. That's fine. I just also want the committee members know that Ms. Bates will make sure if you get that information to Ms. Bates, that she will distribute it out to everybody. But if you want to respond to her, that'd be fine. I think you also have a follow-up question as well. Is that correct?
I do have a follow-up question. I'm happy to make that available. Probably this discussion is most useful when everybody has a copy of it.
Okay.
And actually, I would love to present on it because we published it, and sometimes you do a lot of work and it doesn't get a lot of attention. So
Okay, we made note of that, and we'll have you.
that'd be great. I'd
Sure.
love to be able to talk about it in detail because there's a lot of work that went into it. Incidentally, it's from individuals that were a part of the Ombudsman's office back when it was in the cabinet. So it's the same people who worked at it previously, who worked on this particular document, and I think it has a lot of useful information. I did have a question, though. Thank you, Mr. Chairman. From your report, you talked, and you forgive me if I missed this as you were answering it, but the $300 million that you talked about from the Pharmaceutical Rebate Fund, you mentioned about the restricted fund, and I wasn't quite clear. Has that restricted fund been raised, which would possibly allow some of those dollars to be used to offset some of the proposed cuts? Or are you still waiting for a raise in the restricted fund?
No, that restricted fund was already increased.
Okay.
It's not a part of the cuts, no.
Okay, thank you very much.
These are not new dollars, all right? So when we used to do this, it was a offset of expenditures, all right? So on the state and the federal side. Now I have to treat the state side as a revenue source. So I had to have the appropriation increase in order to spend those $300 million.
Very good. Just by clarification point, it hasn't changed anything you're saying. It's just the function of how it's being
Just
processed.
the function of the way it's processed, and it made it look like our budget increased by $300 million, in which it didn't. It did in appropriations, but not in total spend.
Very good. Thank you.
Yeah.
All right, well, very good. Thank you for the questions, and also thank you for the responses with that. If you don't mind, let's just go ahead to our next item on the agenda, which is the 2025-2026 session update. I assume Commissioner Marks is here. Hello, Commissioner. Thank you. What we would like to do, this report that they will give us an update on, we've asked them in regards to the Pharmaceutical Rebate Fund and the Behavioral Health SUD scorecard from House Bill 695 from the 2025 session. We also asked for an update on the community engagement and cost sharing implementation, the withdrawal of 1115 waiver from the House Joint Resolution 24 and the update on the dental reimbursement increase provided in the budget in 2026. I will not ask you to raise your hands, but Miss Martin. No, you don't have. You're good.
I'll raise them both.
Go ahead and transfer that.
Okay.
So, Miss Commissioner Marks, thank you for raising your hand. Do you swear and affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Very good. Thank you. Make sure the microphone is up. Very good. Okay, you all have the floor.
So I'm a little technology
Challenged?
here. So how do I get this back on the screen? If someone can help me on that, I'm a numbers guy, not a tech guy. All right.
Hey, you want this?
Thank you.
All right, thank you very much. I'm excited to present about this scorecard. This has been a collaboration within the cabinet that actually began in 2018 to design a quality and outcomes scorecard or a dashboard that was originally focused on addiction treatment providers. But House Bill 695 expanded the scope of that work to include mental health providers, to also make this scorecard publicly available, and it directed its use by all MCOs, which is a nice addition. The provider types that I'm talking about in this scorecard are under different Medicaid provider type categories. And so that includes all of our behavioral health services organizations, our multi-specialty groups, our psychiatric hospitals, our psychiatric residential treatment facilities, community mental health centers, and then within the licensure category of BHSO, behavioral health services organizations, also alcohol and other drug entities. And so I say all of these to say that this is a wide range of behavioral health providers across our state. It comprises nearly 600 different providers. These are not individual clinicians, these are provider groups, so that's important to keep in mind. The focus of the scorecard is quality outcomes, which is incredibly important to the work that we're all doing in this Commonwealth, and something that we're striving to define nationally at the same time. And so what we did is we selected indicators in Medicaid claims that indicate behavioral health recovery. So some really, I think, innovative work here. And what we've done is we've thought about what those indicators of recovery look like, again, through Medicaid claims. And we identified a couple initial indicators. And that includes that we know that if we see decreased mortality as well as non-fatal overdose, if we see decreased emergency department utilization for addiction and mental health services, if we see decreased incarceration, and if we see less need for inpatient level of care for addiction and mental health services, that we think those are indicators that providers are delivering quality services. So that's the rationale. And what we did is we took all of these indicators and we created a score, 1 to 5 for each of these. And we compare an individual provider against that provider type group so that they can be compared amongst their peers. And then we take those individual scores and we average them. So this is all available publicly. The link to the scorecard is included in the presentation. But I've got a few screenshots to show you the 3 primary ways that we break out the data for you. So next slide. Thank you. So the first way that we do this is we look at providers' average score, which I said from 1 to 5, and we compare them to every other provider within that provider type. And that creates a ranking system. I've blanked out the specific providers. I didn't want anyone to feel especially called out in this presentation. But you can go through and you could say, I want to see within behavioral health services organization who has the highest score and who has the lowest score. Next slide. What we can also do is look at an individual provider's performance over time. And so this takes the last 14 quarters of data, and we can see how they compare against the average, again, of their provider type, with sometimes their performance exceeding that of the average and sometimes dipping below. And then final slide. We can also look at any individual provider right now and see on the individual outcomes we've selected, which is also further broken out by different time periods, how they compare to their provider group, with green triangles indicating that they are above average on an outcome and red triangles indicating that they are below average. We are going to continue to work to enhance this dashboard. I think it is it's really kind of groundbreaking in what we've developed, but there's opportunity for refinement. We're working with our MCO partners for their utilization. We're getting feedback from providers as they look at their scores as well. And we will continue to use this for continuous quality improvement for our provider community. Thank you.
Very good. Thank you. Let's see. Senator Douglas, you'd like to question? You have the floor.
I do, Mr. Chairman. I do have a question. Is there a list of the clients who are being treated, and is there any cross-checking between our provider clinics regarding patients being treated? I know that I've had a number of people come to me talking about some of our clients going from one provider to another provider, and therefore getting multiple treatments from different clinics. So my question is, I return, is there cross-checking as to whether those clients have been treated before and by whom?
Yeah, so there's a couple things that happen. Certainly when there's an intake at a clinic, they ask for their history, their treatment history, and so there's assessment that's done at the individual clinic to understand where they might also be. And I won't speak for Medicaid, but certainly when MCOs have prior authorization and review to approve services, they're looking at concurrent services from other provider organizations, and that would be a check on utilization of multiple providers. We also know that in some cases, in many cases, there may be multiple providers specializing in different areas of behavioral health that might be appropriate together.
If I may, Mr. Chairman. Yes, sir. Go ahead. Thank you. In doing that cross-checking and asking about previous treatments that certain clients have had, how deeply do they go into whether or not those clients completed treatment programs? I'm just trying to figure out, when you're collecting the data, to what extent you are collecting that data. Are we only collecting data from people who have, when we're asking these providers, are we asking only for those who have completed the programs, or are we asking just who's been involved in your program?
Yeah, so to be clear, we're not asking providers to report back to us the patient history that they've taken, and so that data is not coming. But what I would say is that the way this dashboard assesses is anyone with any provider interaction is included in this, and so it is a complete capture of all services provided for Medicaid beneficiaries.
Go ahead, Senator.
Thank you, Mr. Chairman. The dashboard is meant to do what?
Yeah, so could you go back to the very first slide, please? So this was the language in House Bill 695. It directed the cabinet to present a publicly available scorecard that evaluates mental health and addiction on quality outcome measures to be used by all managed care organizations.
Okay, if I may, the concern I have in this particular presentation is quality of outcome, because I have, with all due respect, right now I have no idea what that means, because we're already saying that we are evaluating treatment. We're looking at essentially patient contacts, client contacts. Yeah, we can talk about the treatment, but we're talking about contacts. And I think I'm glad we're going through this, because this will help us develop a model that says, let's see what our outcomes are.
Right, and but that's what is exciting about this dashboard is it's finally asking about outcomes. Have you had a non-fatal overdose? Are you coming back to the ED? We're not just doing the kind of historic bean counting of how many services did you receive. We're saying meaningfully for the patient, are you healthier and than you were prior to coming into treatment? So we've got a lot of way to go in continuing to identify those indicators, but I think we're on the right track here.
I do too. I think we're on the right track, but having been in this business for a number of years, just a few years, I'm looking at endpoint outcomes, and you know, as we take a look at some of the data, and some of the data would suggest that 87% of the people who enter substance use disorder clinics return to using their substances within 3 weeks, but they still complete programs. And so that's a huge concern that I have, and I'm the guy who talks about the elephant in the room, because I want to make sure that our not just our taxpayers are getting their money's worth, but those people who are going through these programs are getting the most out of the programs that they can get. So I'll be checking into this. Thank you very much.
Thank you.
Thank you, Mr. Chairman.
You're welcome, Senator. Mr. Shannon, you have a question?
Just really a comment, Senator Douglas. I agree with you on the outcomes. I think the behavioral health world is somehow complicated by that. The pattern of addiction is a recurrence. So you'll see that. I've known people who've been through many programs long before they ever get to sobriety. So I think just looking at that doesn't tell the big picture. You know, the slide shot is really negative, but the macro is a person gets there. And just in my own life, I have 3 people come to my house for dinner once a month, and they're all in long-term recovery. They've all experienced success, but they had really hard times getting there. So when you look at it data, how many times you go through a program, each time you make a little bit of progress, right, Commissioner Marks? A little bit of progress. It's not a fix. It's not a broken limb that gets set and you take the cast off 6 weeks later and life is better. This is a challenge of substance abuse and people with chronic mental illness who will tell you, I don't like my medication. My family likes my medication. I don't like my medication. So part of the challenge is getting to that place for people. It really is challenging. And I do appreciate, I would love to talk outcomes. I think outcomes is what should drive this thing. But let's figure out what those really are. That's doable for the individual. And what do they want to see happen in their lives?
Well, unfortunately, we have enough people who are involved in the system that often what we strive to do is we strive to find outcomes from the exceptions. You know, I'm the person who stands up and says, when we legislate, when we do some of these bills, we need to be legislating for the masses and then doing amendments for the exceptions. And some of the folks that we're talking about here, we come in here and we talk about the exceptions a great deal, and the masses get lost because we don't spend enough time talking about what success means to those masses, because we put them in the wrong category. We put them in the category of some of the more challenging groups, and the masses get lost. And my concern is for the loss of those masses, the mass of people who are in substance use disorder. So that's really what I'm alluding to. But thank you. I really do appreciate that concern.
And I just want to make a comment and then I have a question. Part of that, Mr. Shannon and Senator, we went through the process, I believe it's Senate Joint Resolution 74 in terms of mapping, and that will be embedded in terms of having outcomes. Unfortunately, that was vetoed, as you know of. I like to believe that we're going to resurrect that at the next session in order to have a good mapping, tracking mechanism so we can have an understanding of where the money's going, what's the production, how successful are our Kentuckians out there in getting them help, particularly in your neck of the woods in terms of mental health. So with that, Commissioner, I do have a question. Hold on, Representative. Was this internally worked on, or did you contract this this out?
This was internally worked on.
This was internally, okay, because I know there was a discussion down the road of having it contracted out. Okay, well, thank you very much. Representative Mosier, you have the floor.
Thank you, Mr. Chairman. Thank you for your presentation. I'm looking at the slide on provider scores, and I'm wondering how these rankings are used.
Yeah, so we're still exploring how they're used. The idea is that ultimately the functionality is in continuous quality improvement for each individual provider, as opposed to just a pure ranking system. I know that we've floated many ideas, and we're talking to our MCOs about how they best use this data. Gold carding comes to mind as something that's been presented by you in terms of saying, look, this is an objective demonstration of quality, and so maybe there's a pathway for them. But right now, what we want to see happen is both the MCOs and providers to look at this and to understand their data better. They often don't know about fatal and non-fatal overdoses when someone's discharged from their program, and if they see exceptional rates, that's new information for them to think about how they how they will improve their programs.
May I have one more quick question?
So we're going to go to the senator after you, Representative. I'll have one more question, and then we'll need to move on. But go ahead.
Okay. While we're talking about ranking and using data and metrics, is there an opportunity somewhere down the line to rank services and take a hard look at outcomes and how they're performing and whether or not those services that we're funding are making a difference in the lives of Kentuckians?
So interestingly, that's how this started, and associated with legislation that you passed. We started with looking at the residential level of care for substance use providers, and so that was the orienting framework, is if you enter a residential level of care, what are your outcomes for those clients afterwards? And so we do have the ability to pivot this towards, I think, levels of care, probably more so than individual services. It probably gets too granular at that level, but that's entirely possible. Yeah.
Thank you, Mr. Chair. And one of the comments that Mr. Shannon made about families liking the provider, but possibly the client not liking the providers reminded me of the Medicare inpatient surveys that used to ask the question, how well did the provider control your pain? And tied directly to reimbursement. And as a result of that, I think there was a significant increase in the prescriptions of Oxycontin and so forth. So I'm curious as to how this information is going to be used. Is this used for value-based purchasing, or is it intended to be, in the future, used for value-based purchasing for services?
You know, I look to our MCO partners as the entity that's directed first and foremost to leverage this data to think about how they do move towards using data to drive their purchasing decisions and their quality control decisions. But it's certainly possible. I think there's research that needs to be done at the same time, right? This is really on the cutting edge to rank these providers in this way and create these scores, including risk adjustments and those things. And so I think we want to continue to be a leader, but be really thoughtful as we engage in this work and tie it to payment methodology.
That's what I thought you would probably say. And certainly, Mr. Chair, I think we'll have some more discussion about this in the future, but
Yes, sir.
I thank you for that.
You're welcome. One last question we had, and then we'll move on to the next topic. Commissioner, I wanted to, if you said this, forgive me, that I might not have heard you. When did this go live? When was the providers communicated about this going live, and what's involved, and how is that communicated?
Yeah, so the legislation required that this go live, I believe, prior to January 1st or right at the end of the year. So that's when it went live, is before the deadline that was established in the statute. We had a quick turnaround because this was passed in June of the year, and so we had 6 months to build it. We did do individual provider focus groups. We reached out to some leaders in the community and asked them to review and look at it with us. We also met with the MCOs on several occasions and asked them to review the dashboards and made improvements from there, and then it was released.
Okay. Well, thank you. I've had quite a few comments that they didn't know anything about it.
Okay.
From providers. So I would appreciate if you just increase your communication out to the folks and let them know. I think it's a good I think it's good. That's why we put it in there, to make sure we have a good scorecard so we can hold ourselves accountable, as well as providers and well as other folks. So anyway, thank you very much. Here, I'll just use yours. Let's see. They haven't done. Okay. Ms. Bates reminded me, we also, could you provide an update on the community engagement and cost sharing? I don't know if you've already had that in the queue, but I know I just want to keep things going. Also includes a 11115 waiver, as well as a dental reimbursement. If you don't mind commenting on that, I appreciate it.
Absolutely. Regarding House Bill 500 and the dental reimbursement appropriation, the Department for Medicaid Services staff has been working very closely with the Dental Technical Advisory Committee within the Medicaid program, and we are working with them to identify the best way to utilize those appropriations to make sure that we're doing the best thing for the dental community and specifically for our members. So we are continuing to work on how best to appropriate that. For example, they're looking at specific codes rather than just an across-the-board rate restructuring. Regarding House Joint Resolution 24 and the 1115 waiver withdrawal, that letter has been submitted to CMS. House Bill 2 and community engagement implementation. We have been working very hard to design our system. As you know, beginning January 1st of 2027, individuals between the ages of 19 and 64 who are enrolled in the Medicaid expansion population will have to meet work requirements in order to keep their eligibility. So we have been designing our system. We've been working with CMS. We have routine meetings with them. They are looking at our system. We have to demonstrate the system is in compliance with all federal regulations. So beginning January 1st of 2027, individuals in that group will have to either work 80 hours per month, or they will need to participate in job training or volunteer activities, or a combination of those in order to get 80 hours, or they could also go to school or earn $580 per month. So beginning in January, we will have an application of an individual who is a newly applicant will have to meet those work requirements for the month preceding the date that they apply for Medicaid. Individuals who are renewing will have to meet those requirements at least 3 months in the previous 6 months within the month that they are what they are applying for. We do have some individuals who will be exempt, such as individuals who are caretaker relatives of individuals such as 13 years or below. There will be some other individuals, such as maybe those who are being treated for substance use disorder. We did have a medical frailty condition, and the federal final rule was just released this month. Our medical frailty condition would be that we would exempt anyone with a specific diagnosis. However, the new rule has said, the new interim final rule states that we cannot just blanket tell individuals that they do not have to meet those requirements. We actually have to assess them. So, for example, if someone has cancer, we can't just say you do not have to meet work requirements. We have to assess them to see if their condition is such that they would be able to meet those work requirements. So that's a little bit of a change for us that we're going to have to really implement and think about how we design our system and what sort of mechanism that we can have to ensure that those individuals who have a specific diagnosis can be exempt from the work requirements as we go forward. We do have a timeline. We started, again, the final rule came out in June. July 1st, we have to send notices to everyone who is enrolled in Medicaid in the Medicaid expansion population. August through November is going to be finalizing our system, doing testing. We're also going to have some stakeholder engagement, and outreach notices will be sent to newly impacted members. So we have to do, according to federal rules, we have to do an outreach in July, and then we'll have to more going forward. December 2026, our Medicaid eligibility system has to be completed with all of those requirements, and we go live on January the 1st of 2027. In February of 2027, that will be the first renewal period for those individuals who have to meet community engagement requirements. So, for example, individuals coming up for renewal in February of 2027 will have to meet those work requirements in 3 of the previous 6 months. The cost sharing that's outlined in House Resolution 1 goes in effect 2028, and right now our efforts are being focused on community engagement activities to make sure that we meet those requirements by CMS.
And that's understandable.
Yes.
And I know the y'all are under the gun. I do appreciate the update. I know there's a lot of some system changes you'll have to go through and look at. Obviously, we're here to support that endeavors. I know, like I said, y'all have got a challenge ahead of you. Do you anticipate any problems or issues coming out that will cause you to delay the implementation of this?
Not at this time. Again, we have meetings with CMS on a routine basis, and they're constantly looking at our system, making sure that we are meeting the guidelines that we have to come into place. And again, the medical frailty issue that came up, that has thrown us for a curve, because it's going to be very difficult. I mean, we can identify anyone with a specific diagnosis, but then drilling on into that to see if they would be exempt or not is going to be a little bit of a hurdle for us to get over.
Yeah, and in terms of that medical frailty, I sort of scratched my head when I saw that as well. So, but in any event, is there any questions from the committee? Chairman Meredith, go ahead.
Just a very brief question. I think we're already seeing a decline in Medicaid enrollment. It hasn't been substantial, but it's declining. Have you all made any attempt to make a projection of what we may see over the next year in terms of the reduction in number of Medicaid enrollees? And if so, did we use those numbers in formulating the budget for this next biennial period?
I will defer to my CFO to answer that question.
To answer the second question, yes. We used those our consensus forecast. We came together. Can y'all hear me? Is this going? The consensus forecast that we came together, we did look at and model some of the redeterminations to 6 months, as well as the community engagement. Now, I will say, I don't know the numbers off the top of my head on what we thought that was going to be. I can get that for you. It's built into our forecast. But I can say that the majority of our decrease was more tied to the 6 months redeterminations process versus the community engagement piece. And the reason why is we used the most recent data and experience with the redetermination process of people just not showing up. So we use that in our determination of our enrollment decreasing. So, but we do think that majority of the decrease will be tied to the 6 month redetermination. But now, when we did do this community engagement, medically frailty was a different animal. So, so we have not updated those based off of that.
Do you have a ballpark number as to what you're speculating it could be, the percentage-wise?
I want to say it was like 20% of people not meeting the requirement.
Okay, thank you. Thank you,
Thank
Mr.
you,
Chair.
Chairman. We have one more question, and Director Hicks, you have the floor.
Yeah,
I'm
thank,
sorry.
thank you, Mr. Chairman. Just Steve didn't bring them with him, but in the budget forecast, there was an estimate in fiscal year 28, because that's when both the work requirements, community engagements, and the redeterminations combined. It was over 28,500 fewer enrollees incorporated into that forecast.
Thank you, Director. I correct myself. We have one more question because he has not asked a question yet. So go ahead.
Actually, more of a comment than a question. The dental community would like to express our gratitude to the legislature as well as the commissioner for the efforts for the reimbursement appropriation. It is the first that we've had going back to, as we've discussed in this body, looking at 1997 fees, 75% of 1997 fees. It is extraordinarily, we're extraordinarily grateful and appreciate the understanding of the impact on oral health and on general health that this appropriation will create. There's still work to be done, as we know dentistry is not tied to Medicare or to any cost of living increase or any inflationary increase. So we still have concerns of the future as to where rates will be down the line. We also have concerns that this fantastic appropriation still puts us well below the average of the southern states in their fee schedules and their fee structures. But the movement is fantastic, and again, we appreciate all the efforts made on our behalf.
Thank you very much. Thank you all for coming and making that presentation. So with that, you can stay there if you want, or you can excuse yourself, whatever you want to do. I'd like to go ahead and move on to item number 5. In House Bill 2, the bill set up 2 subcommittees and 1 work group. And so Senator Adams and I have notified and let people know of who will be participating in these various groups. And I'm just going to go ahead and read out the names, and I'll just go through somewhat quickly. On the healthcare transparency dashboard, we have UK Representative Mark Birdwhistle, U of L Representative Ken Marshall, Representative Kim Mosier, Senator Steve Meredith, Secretary Stack or his designee, and Allison Adams from the Foundation of Health Kentucky. In regards to the waiver waitlist dashboard, we have Representative Wade Williams, Representative Lisa Wilner, Senator Craig Richardson, Senator Karen Berg, Commissioner Lee or her designee, Mr. Shannon, Steve Shannon, and Miss Amy Stead. They are advocates that are participating in that. And the last is the Non-Emergency Medical Transport Work Group. We have Representative Adam Bowling, Senator Mike Nemes, Commissioner Lee or her designee, Mr. Jeremy Thomas of the Kentucky Department of Transportation, although he is retiring, but somebody will replace him. Pam Shepard from the Federated Transportation Broker, and then Robin Whitaker from the Daniel Boone Community Action Transportation Provider. It's the Senator Adams and I will communicate with each of those groups in terms of the who will be chairing and so forth, and so we will work together and contact those particular groups. Okay. All right, so we'll move on to item number 6, the public comment. I just want to let folks know that some documents were presented to us, and we do have those. We will make copies and make sure that the members of the board receive those that information. Ms. Schuster.
I didn't raise my hand quick enough when you were talking about the work groups and subcommittees.
Yes, ma'am.
I've had several people ask me if those meetings, obviously they're open, they're on the LRC, the interim calendar and so forth. Will there be a period for public comment at those meetings?
That's going to be a decision of the subcommittees and how they want to structure and how they want to go through that process.
I would recommend, certainly for the waiver work group and for the NEMT, that they would entertain comments from the public. Thank you.
Thank you. Thank you for your comments. Okay. Okay, we have several individuals that would like to make a presentation. Basically, you have 3 minutes, and you can make a presentation. And I'm going to call off several names in a row. And if you're in this room, great. If you are in one of the other rooms, if you do hear your name, if you don't mind, just make your way into the committee room and be ready to go to sit at the panel. So if I have a hard time pronouncing your name, please forgive me. When you come up here, please correct me, and I'll do the best I can to pronounce the names and so forth. So the first 4 I will call is Mr. Scott Brinkman, Mr. Bruce Perfect, I believe, Dr. Robinson, and Mr. Bill Keneally, I hope. So if I read your name, if you don't mind, just make your way up to the come up to the desk. You can sit with Mr. Brinkman. Yeah, is everybody up here? We have.
Yeah, just do 3 at a time.
We'll do 3 at a time. Okay.
Yeah.
We'll do 3 at a time. So I know it's Mr. Brinkman. Who is Mr. Perfect? You are. Okay, great. Dr. Robinson, you're Dr. Robinson. If you don't mind, Doctor, if you we'll just get you in the next group. If you don't mind, just having a seat next to those 2 young ladies there. And you're Mr. Keneally?
I am.
Okay. All right. Mr. Brinkman, you're first on the list. You go right ahead.
Thank you, co-chairs and members of the board. My name is Scott Brinkman, and I'm here as a parent of a child who is being served by the Lee Specialty Clinic. Our son David is almost 42 years old. He has autism, he has developmental disabilities, and he has some behavior challenges. David has been a patient of the Lee Clinic for over 11 years. The clinic opened in 2014. David became a patient in 2015. Before that time, my wife Donna, who is David's primary caregiver and certainly his fiercest advocate, spent countless hours trying to find Medicaid providers in Jefferson County who would attend to David's healthcare needs, including his behavior issues. This was a very arduous and frustrating process for my wife. We live in Jefferson County, our most populous county, so you can imagine what it's like for the individuals and families who live outside of Jefferson County and the surrounding counties, live in other parts of the state, including the rural parts of the state. It's why the Lee Clinic is serving over 1,300 individuals and families. It's a model that probably has far exceeded the expectations of its principal advocate, Representative Jimmy Lee, with whom I had the privilege to serve for 10 years in the General Assembly. The clinic is a model that's working, and it's addressing a pervasive need that exists throughout the Commonwealth. And for the individuals who are served by the clinic, change and disruption is really hard. Continuity and familiarity is very, very important to them and their families. And the staff at the clinic is just remarkable. These are healthcare providers who are willing to tend to their healthcare needs, their medical needs, oftentimes very complex medical needs, their dental needs, their behavior issues, and others. And it will be very disruptive if the decision of the cabinet stands. In fact, it will wreak significant hardship on these 1,300 individuals and families. Individuals and families who already suffer enough hardship and don't deserve to experience further hardship, certainly under circumstances which are completely avoidable. So as a parent of a child being served by the clinic, served exceedingly well, I'm asking the cabinet to reconsider its decision and do so before it's too late, because once staff at the clinic begins to leave for other positions, which they will have to do by necessity because they have needs that need to be addressed, they have paychecks that need to be received, before the operations are so severely curtailed as they will be, please reconsider the decision, because if this were to occur, it's going to be very, very hard to reconstitute the operations of the clinic. It will not happen overnight. It will take a long period of time, and in the meantime, these 1,300 individuals and families are going to suffer severe hardship. Again, hardship that they don't deserve to experience. They all experience enough hardship in their daily lives as it is. So thank you, co-chairs, members of the board, for allowing me to make these remarks today.
And thank you, Mr. Brinkman, and thank you for your service to the Commonwealth for all the years you did, not only on both sides of the government. So thank you very much, Mr. Perfect. You're next on the list. Make sure your mic is on and close to you. Thank you.
Yes. Thank you for allowing me to speak today. My name is Bruce Perfect. My son Greg is alive because of the Lee Specialty Clinic. For 2 to 3 years, starting in 2015, Greg was in and out of hospitals because he was basically wasting away, vomiting himself to death. He also had bowel issues and severe behavior issues. None of the doctors who saw him could diagnose why he had these issues, nor could they get him on the right medications. So he was not a threat to himself or others. The doctors ultimately told us there was nothing they could do for him, so they put him in hospice care, and they sent him home to die. His mother and I refused to believe nothing could be done to save our child. When we finally found Lee Specialty Clinic through God's grace, it was our last hope, and because it became the answer to many prayers. At Lee, he was quickly diagnosed with Phelan-McDermott syndrome. Severe vomiting and autism are part of this condition. He has been receiving treatment for it ever since. Today, he's not only alive, but he is in great health, and he has a quality of life that we always hope for him. The doctors at Lee have also been able to accurately prescribe medications for his severe behavior issues too. Lee is called a specialty clinic because they specialize in treating intellectually and developmentally disabled people and the unique health and behavioral needs they have, like my son. My family is just one example of the families from across Kentucky who travel to Lee so their loved ones can have access to care from healthcare providers who are specially trained to meet the healthcare needs of people like my son Greg. I implore the governor to restore the funding that was in the budget to keep Lee Specialty Clinic whole, so none of their patients have to go back into a health system care that is not specially trained to care for them and cannot care for them properly. Lee Specialty Clinic has the ability to not only save the lives of the patients and make their lives better, but the clinic gives their families and caregivers hope. And without hope, you have nothing. Please don't take our families' hope away by pushing our son out into a healthcare system that left him for dead, and could do the same to the over 1,000 patients who will no longer have access to care at Lee Specialty Clinic. I would like to say in closing by saying, by God's glory and grace, He led us to Lee Clinic and gave their staff incredible knowledge, love, compassion, and perseverance to care for our son like no others ever had. We are pleading with you to please restore Lee Clinic's funding. Thank you. We also brought a picture of Gregory before he came to the Lee Clinic and a present picture of an incredible recovery, and we'd like to show them to you also. Thank you.
Thank you very much. Go ahead. You have the floor for 3 minutes.
Thank you. Good afternoon. My name is Bill Keneally. I am the current president of the board of the Council on Developmental Disabilities, which has existed since 1952. We are an advocacy organization. My son Danny, who is now 36, has been a patient at the clinic since 2014, when his mother and I were featured in a New York Times article talking about the clinic. I would ask you to review the materials that we've worked hard to produce and outline what will happen to our population, our people, our humans, if this clinic closes. It will be a catastrophe. There will be more than 1,000 people who will descend upon an unwilling and unprepared medical and dental treatment system, if you want to call it that. Hospitals turn away our people. They're turned away at Central State because they have dual diagnosis. This has gone on for decades. The only thing that's going to save them is the continuation of the clinic. Because once the clinic is gone, as Mr. Brinkman said, it's hard to get it back. I have known the directors of the clinic, and I've helped them over the years. They helped my son. He had self-abuse issues, slapping the side of his head to the point where he's having concussions. He had a cauliflower ear. And Tony, their psychiatrist, figured out, oh, we need a treatment regimen for obsessive compulsive disorder. That's what this is. We found the medicine. It took a few months. It went away. Danny's nonverbal. He can't tell you what's wrong. And that is how most of our folks are. They have to have assistance. And they have to have special treatment. Now, I like to say our T-shirt should say 4% does not equal 89%. Okay? The cabinet has decided to cut our outpatient budget by 89%. We are a licensed outpatient clinic. 90+% of the patients that are treated there are outpatient. So we will be basically taken away. And I've had no explanation for why this was done to the clinic, just that it was done, and blaming the legislature. So why are we, this community, being punished with the loss of the only specialized care facility that we have in Kentucky, why are we a pawn in this political game between the executive and the legislature executed by the cabinet? Why is that? Questions. I'm a lawyer. I ask questions. You'll have to bear with me. Why is this community, us, why do we bear the human costs? Why are we the losers? Why do we have to pay for poor or even no treatment?
If you don't mind, I've already given you leniency of 1 minute over, so you're at 4 minutes.
Thank you very much.
You're welcome. If you have like 15 seconds to wrap up, and then we need to move on. Thank you.
How in the name of decency can the cabinet not only perform medical and dental malpractice? We will follow it. If this clinic closes, we will follow what happens to the patients. We will let the people of Kentucky know what happened to them. Thank you.
The next three presenters, I think Dr. Robinson, Kim Thompson, and Corey Nett. I would like to sort of give a batter up or a batter in the box. Miss Garcia, Miss Griffin, and Miss Tillo. You're the next three, so if you make sure you prepare. So when these three are finished, please go ahead and make yourself to the panel. Dr. Robinson, you have the floor for 3 minutes.
Thank you, sir.
Just make sure it's green and it's close to your...
Thank you.
There you go.
I give glory to the Lord Jesus for the opportunity to speak to these honored leaders of our state. I'm a doctor at the Lee Clinic, Dr. Paula Robinson. I'm also the mother of a Lee Clinic patient, my son Kevin, who has been a patient there since 2014. If you had a precious 3-year-old that somehow was in an adult body, where would you take that person for medical care? And what would they do to him to make him manageable? They would medicate him until he was in a stupor and not running around. They would give him stacks of medications that have interactions that cause terrible effects on the body, including bowel obstruction, fatal arrhythmias, a predilection for heat stroke, falls, as well as the psychiatric effects, dysphoria, frustration. Your 3-year-old can't communicate. He can't tell you when he has a urinary tract infection or an ear infection. He doesn't know that there's help in the building, so he won't get out of the car. At the Lee Clinic, the dental hygienists and the speech therapists and the administrators will walk out to the car to help you get your 3-year-old into the dental chair so that he can have an abscess tooth treated. And if he has high blood pressure in that dental chair, they will walk across the hall and get me so that I can come and assess whether he's safe to continue with treatment. I'm begging you to keep the Lee Specialty Clinic alive for the outpatients that need us. I pray night and day that not only will the Lee Clinic be saved, but that there will be a Lee Clinic in every county in Kentucky. Thank you, and I'll take questions if there are any.
Okay, thank you very much, Doctor. Appreciate your presentation. Ms. Thompson, you have the floor for 3 minutes.
Thank you so much. Many of you probably know me because I've been in here as a parent advocate over and over again about the lengthy 1915C home-based and community waiver wait lists. I'm not a paid lobbyist. I'm not paid in government. I'm not really paid doing anything. I spend my time as a mom boots on the ground, making sure that my child is taken care of. He is 29 years old. My child has never had a medical diagnosis outside of autism, pervasive developmental disorder, and moderate mental disability. 1 month ago, thanks to Dr. Paula Robinson, who you just heard from, ran a genetic test, a very thoughtful one. She had some suspicions, which I don't think very many doctors would have been inclined or have even thought about doing. And guess what? We got an actual diagnosis. It actually came back. And that diagnosis is extremely significant. It's significant in the ways that deal with his treatment, with his cardiovascular system, with his kidney function, with many things to do with his neurological condition. I am so thankful for this clinic and for what they do. The multidisciplinary medical treatment that my son receives is just top notch. I've heard the term used, unicorns. These employees are unicorns. They are different. This is not like a regular medical facility that you could just walk into. Everyone is highly specialized with an adult intellectual developmental disability population, and they are working day and night to treat this population. I encourage both the legislature and the governor's office, the cabinet, to please do not put us or pin us as political pawns in any kind of game about funding the clinic. We know that the support is coming from the legislature, and I know it's coming from the cabinet. But for some reason, a ball got dropped, and for some reason, the patients became the ball in whatever game was going on. I just ask that it stop. This is not a political issue. I have my politics. We all do. Okay? That's not what this is about. This is really about human lives. We have people who rely on this clinic. We have employees that rely on their jobs. You know, another concern I had when the clinic was first announced that it was underfunded was, okay, well, we can work to maybe try to save the clinic. There are multiple paths forward that I think maybe we could extend this thing out to the next General Assembly and see if we could get another budget going. But employees could leave in that time. You know, I don't even know if employees have already left or started looking for other jobs. If they go, we're not going to get them back. And that's a real problem. That's a real problem too. So you have just put an entire population of people in jeopardy. And I just ask that we all work together to find a solution. It is very important. And I respect the legislature. I respect the cabinet. I respect the governor's office. Just please do not make this a partisan or a political issue in a game where people's lives are at stake. Thank you.
Thanks, Hoffman. Mr. Nett, you have 3 minutes.
Go and with my government.
His name is Corey Nett, and he's going to let me speak for him to give us more time. So Corey Nett, he has cerebral palsy. He's been a patient at Lee Clinic for about 10 years. Since his discharge, this is the first time in his life he's not been able to under a doctor's care, which is very scary. And because of the medicine he takes, he needs to see a doctor monthly. We have all heard the old adage, show me your budget and I will show you your morals. The budget from the General Assembly is morally bankrupt. The most vulnerable should not be pawns in your political game. We deserve to be treated like human beings. This draconian budget will cost our taxpayers more in the long run because this population won't be likely to find doctors that want to see them, forcing them into ICFs, which costs $500,000 to $600,000 per person per year. Not to mention their quality of life will decrease. The staff at Lee's is exemplary, and they are like an extended family to these patients, going above and beyond with their care and compassion. And from experience, I know that no other place will give this population the respect that every human being deserves. It would, if only 14 patients were to go into ICFs, that would equal Lee's yearly budget. And for those who don't go into ICFs, their primary care will probably be the emergency room, and people will die. So are we really saving money? Please consider reinstating Lee's budget. We know our rainy day fund is at a record $3.7 billion. There are thousands of people's lives at stake here, and if this isn't fixed, we're showing the country and the world that in Kentucky, people with disabilities are expendable.
I want to say thank you. I just want to thank you, Mr. Nett, for coming here and spending the time. Your voice is strongly heard. We are with you 100% of the way, and we understand the challenges that y'all have. So thank you, and peace be with you. The next, we have Ms. Garcia, I think Ms. Griffin, and Ms. Tillo. Are they here?
Garcia.
Got two. I need one more. Okay, so Mrs. Garcia, you're next.
Good afternoon, you guys. My name is Star Garcia, and I come to you today as a mother, a caregiver, and the chair for the National Council of Severe Autism. I'm sorry, I'm a little emotional just because I have to have my son here. So
that's all right. Take a breath.
It's incredibly hard as a single parent coming here, you guys.
We understand. Take your time.
My son turns 18 on Friday. Sorry. Most people celebrate that. I'm really sorry. My son turns 18 on Friday, and instead of celebrating, I'm worried about where he'll go, because at 18 he's going to lose access to Cincinnati Children's. I've already reached out to Lee's Specialty Clinic, hoping that if my son needs stabilization, that we could go there, but there's a wait list. The reality is that's what I'm preparing for, because my son is suffering from severe medication reactions, and his eyes roll back in the head, in his back of his head. Okay, that's what the specialty looks like. I was a 4.0 student. I once saved Procter & Gamble millions of dollars my first year working there. And I'm not saying that to impress anybody, because I'm sharing that because I think you guys need to know that I am not here because I gave up. I stopped working in a traditional sense because my son needs me. I'm his biggest advocate. I'm his #1 fan, and I didn't have a choice. And caregiving is now my full-time job. I've had to map out safe people, safe places, learn his triggers, and notify the local police about his needs, so that when a crisis happens, that I can pray that he's going to be met with empathy instead of escalation. CPS has been notified. They have been coming to my house, not because of my son's safety, but because of mine. These are not edge cases. These are the daily realities of families who depend on Medicaid, not as a convenience, but as a lifeline. Of the more than 200 applied behavioral analysis ABA providers listed in Kentucky offering a service that can mean life or death for these autistic individuals, 30 to 40 accept individuals with Medicaid, and with that, lots are on years wait. This is what's going on before the cuts, okay, before the cuts. So, as a full-time caregiver who actually has to rely on Medicaid, I am deeply concerned. I'm deeply concerned what comes next. We are already struggling to find providers, and every reduction pushes families closer to the edge. My fear is not that services will become hard to find, but that they're going to disappear altogether. too many Medicaid conversations are being centered around who deserves it most. That framing is both wrong and dangerous. Medicaid supports nearly everyone at some point after an accident, during a pregnancy, through a serious illness, or to support a disabled child. If I leave you guys with anything today, please hear me when I say that healthy communities benefits all of us. And vulnerable families, we're not talking points. Families like mine, we're not asking for special treatment. We are only asking for the opportunity to keep our children safe, home, and healthy. I love my son. We all love our children, right? So I'm here because families like mine, we're exhausted, we're overwhelmed, but we're still showing up. We need our policy makers. We need you guys to show up too. Please do not wait. Please do not wait until the services in Kentucky that families depend on are gone. My son is not a budget line item. He is a person, and his life is worth protecting. Please work together to fully fund Medicaid, to keep Lee's clinics open, and I'm gonna go a step further. Please expand Lee's clinic, because this shouldn't be the only clinic that can service our individuals. Thank you, guys.
Thank you, Ms. Garcia, for your testimony. Our heart breaks for the challenges that you have. We have, I guess, Ms. Griffin?
Yes. Yes.
Okay.
Hi, how are you?
Yes, ma'am. You have 3 minutes. Go right ahead.
My name is Tanae Alexia Griffin, and I am the Executive Director of Flowers Movement Events Incorporated, and we host self-care events for adults with intellectual and developmental disabilities, and a lot of our loved ones attend Lee Specialty Clinic for their healthcare services. So it's a shame that we all have to be here today to advocate for this, as this is a very vital need. And Lee Specialty Clinic is the only clinic in Kentucky that can service these families. And the crazy part about this is that they have the specialized equipment needed for these folks, because a lot of these folks have been turned away from your standard hospitals, okay? They're not able to handle self-harm. They're not able to have the right equipment and the right tools. And these are specialized staff. And this staff, like, not all heroes wear capes, but they do. Our therapists, our employees, everybody been working hard for this population for years. My brother, who is standing behind me, has been attended this clinic since it first opened. And my mom, the whole Davis family, is here to represent for all the families here today, because they don't have anywhere else to go. So we're all here, and I'm here today not only just to speak for our families, but for all families here. The individuals that are going to be impacted are those with autism spectrum disorder, Down syndrome, cerebral palsy, Fragile X syndrome, Prader-Willi syndrome, Williams syndrome, Angelman syndrome, spina bifida, fetal alcohol spectrum disorder, adults with intellectual disabilities of varying support needs, those that have sensory processing challenges, those adults with seizure disorders and other complex medical conditions. This is not just about one clinic. This is about protecting healthcare access, dignity, safety, and quality of life for one of the most vulnerable communities in this whole entire state of Kentucky. So if this clinic were not to be open anymore and the funding would be shut down, you all are basically signing off on ending the lives of those in this population. This is how serious this is. These specialists are one of a kind, one that Norton's can't take on, Baptist, U of L, they all gonna feel it. And not in a good way, okay? These are specialized staff that still need to be here. The clinic needs to expand. Just as all the other rest of the representatives here have said, this is the only service that our folks that have severe behavioral issues, severe medical conditions rely on. Please put politics aside and bring your heart and compassion to the floor. That's all we're asking for.
My name's Tina Davis. I'm the parent of Terrence Davis.
If you don't,
This is my family. Just one thing.
No, man. If you just speak into the microphone, I'm not
sorry.
trying to cut you off. I want to make sure you speak.
Okay. Let me scoot up here. My name is Tina Davis, and the Lee Specialty Clinic family is my family. They are my family. They are the one that got my son from where. They are the ones that got my son from not being of this world to Special Olympics. He's a rock climber. He's a track runner. He knows how to roll a ball. Yeah. His communication was done from the speech therapist here. They taught him how to communicate. His physical therapist taught him how to go from here to there. His OT therapist taught him how to desensitize his body. They taught him that. I didn't know how to do none of that.
You're not going to get it anywhere else.
And his medical doctor.
Okay.
His medical doctor is the only one that could figure out what's going on with Mr. Terrence.
Miss Davis.
What's going on? All I'm saying is, so with that being said, please fully fund Medicaid so that my son and others receive the Medicaid that won't be homeless, specialized care for them.
Thank you, Miss.
Thank you.
Thank you, Miss Davis. I know you signed up earlier, Miss Davis, and you scratched it out, and that's why I've been more than happy I'm more than happy to accommodate you because I know you wanted to speak, and we're glad we spoke. Miss Tillo, and if before you speak, Miss Tillo, you'll have 3 minutes. We have Nancy Mudd, Amy Cutter, and Arthur Campbell, if you don't mind, to be ready to come to the table. You have the floor for 3 minutes.
Thank you. My name is Kay Tillo. I'm chair of Kentuckians for Single Payer Health Care. And while I don't personally have a family member who is impacted by this, I feel like all of these beautiful families who were fighting for care are a part of my family as well. And we as a society have to take that as a mandate that healthcare is a human right. You have a right to that regardless of your abilities or your illness or your capacity. And those who are elected to represent us have a responsibility to see that that right is fulfilled. And so I express my solidarity with the people who are fighting for this issue and urge you to fund the Lee Clinic and all of the healthcare services that are needed by the people of the Commonwealth. I would like to say as well that we are affiliated with Physicians for a National Health Program. We have come up with a program whereby Medicaid can save some money by ending its reliance on private for-profit MCOs and publicly funding the Medicaid program. I would be glad to share that with you. That's been done in Connecticut. It is one way to make a little change. But I would also like to say that the problem is bigger than what we can solve quickly and easily. We as a society have to take on the task of transforming to a universal, publicly funded, improved Medicare for all that will assure that everyone in our country has the ability to get the care that they need. We pay double what other countries pay per capita, and we get less care. We have shorter life expectancy. We have higher maternal mortality. We have higher infant mortality. We are not using our funds in a way that it serves the people. We need to stop running those funds through the private for-profit industries and instead direct those funds to the healthcare professionals and the services that are needed to give us the healthy society. I urge everyone to help us in backing that and making that a priority that we get passed in our country to bring us into the century where we now live. Thank you.
Thank you, Ms. Teller. I have Ms. Mudd, Amy Cutter, and Arthur Campbell. And just to let y'all know, please, I want to make sure that Miss Marshall, Mr. Hellringer, and Miss Robinson are after this group. So please make sure you're in the room. If you're not, and be prepared to take the table before right when they leave. So Miss Mudd,
Yes.
you have the floor for 3 minutes.
Okay. Can you hear me?
Yes, ma'am. Go right ahead.
All right. Mine's just one small story. These have all been so amazing.
Yes, ma'am.
Our daughter Jillian was born in June. Sorry.
Take your time. It's
She was
okay.
born in June of 2000 and was placed in our home as a state of Kentucky foster child. Her adoption was finalized shortly after her second birthday. She was in First Steps program for the first 3 years of her life, where she received specialized therapies with the hope of early intervention for delays in any area. She was diagnosed around the age of 2 years with childhood apraxia of speech. Her elementary school had her first IQ testing completed around the age of 6 years. This is when we were told. This is when we were told of her intellectual disability. As you can imagine, this was devastating news. A pediatric neurologist tested her around the age of 8 and told us directly in front of her, "You know, she will never be independent." We have seen many different specialties of doctors over the years and have tried every therapy suggested to give her the best possible advantage. She has a social emotional therapist starting around the age of 7 and continued year-round speech therapy. We started her in hippotherapy horse riding lessons around the age of 8, and she competed in equestrian Special Olympics for the next 6 years. We enrolled her in a private school for special needs from 9th through 12th grade, and after graduating, she attended a 2-year post-grad continued education in the same school. We tried to help her find her way with vocational rehab. She has always acted out when frustrated, and there were times when she would get physically violent. As she has grown, it has become more difficult for us to handle her. We had to call the police for assistance on several occasions. Throughout this time, we had assistance from therapists and doctors from 7 counties. After several times in crisis, it was obvious we needed more help. Since we are on the wait list for the Michelle P. waiver since 2017 with no end in sight, we were granted the support for community living waiver in early January of 2024. We hired a case manager and a behavior specialist and got her in a day program for ID adults. Her specialty doctors had told her she had aged out and needed to find an adult doctor. We were on the wait list for the Lee Clinic for 2 years. Our case manager helped us find the right residential housing for ID adults, and lucky for her, the Lee Clinic called to say a spot had opened up for her. The Lee Clinic has been such a blessing. All the staff at the Lee Clinic know how to handle Jillian and to help her feel safe and comfortable, all the while with dignity. Jillian also has low muscle tone, gastroparesis, and GERD, a chronic and more severe form of reflux. This disease has severely affected her teeth, requiring several extractions. Jillian is on 23 routine medications. The complexity of her care is such that typical doctors are not used to dealing with and do not have the proper supports in place to handle patients with intellectual disabilities, high anxiety, etc. Due to Jillian's high level of frustration with apraxia of speech, intellectual disability, and physical ailments, it will be extremely difficult for her to find a doctor that can handle her, much less help her. Jillian loves the Lee Clinic and all her doctors and staff, as do I. Thank you for reconsidering of this critical funding to keep the Lee Clinic open.
Thank you, thank you. Ms. Cutter, you have 3 minutes. I know people want to expand as much as possible, but we definitely need to try to stay within 3 minutes. And your words are very, very important to us. So if you can, just be concise. So, Ms. Cutter, you are next.
First of all, just thank you so much for listening. I think it's such a good thing that you all can kind of come in our lives for a minute, because it's kind of hard. It's hard to understand. I mean, it is. My name is Amy Cutter. I'm the mother of my daughter, Kennedy. Kennedy's 25 years old, and she has profound autism and a rare genetic disorder called Primrose syndrome. She's one of 136 in the world. She's non-speaking, has severe hearing loss, intellectual disability, a degenerative condition that is Primrose that will continue to affect her entire life. Kennedy has always struggled with self-injurious behaviors, hitting, biting, pulling hair. She's done that quite a bit to me, hurting herself and sometimes hurting those around her. But in 2021, everything escalated for me and my family. Her behaviors became so severe that I was isolating myself throughout the day in a room with only my daughter to keep the rest of my children safe. Excuse me. She was attacking herself, which ultimately left her with a cauliflower ear. She was, and myself, a chipped tooth. She was attacking family members. She hit herself. I was desperate for help. I took her to doctors. I took her to specialists. I took her to emergency rooms, every hospital here. Nobody can tell me what's happening. Nobody knows about Primrose. I was so desperate. We were in and out of the hospital for 2 weeks. I just kept searching for answers, trying to protect my family and Kennedy. And then when we came home from the hospital with lots of drugs to sedate her, which were not used, she had a grand mal seizure at her favorite restaurant, getting her chocolate milkshake. We nearly lost her that day. The Lee Center took us as a crisis situation. For the first time, when we went to the Lee Center, we weren't trying to convince people that Kennedy's needs were different. They already got it. For the first time, we weren't trying. We had access to medical care, psychiatry, behavioral support, therapies, and dental care, ophthalmology, all under one roof, which for our kids is huge because they're scared to go to doctors. They've been there so many times. Every doctor appointment was stressful. Every waiting room can be overwhelming. Every unfamiliar environment can trigger behaviors. Most people have never had to walk into a medical office wondering whether their child might hurt themselves, hurt someone else, or be judged for the outroars or screams or sounds that they make that nobody else understands. At Lee, we were understood the moment we walked through the door. The staff knows Kennedy. They love her. I think that's safe to say. They know how to keep her safe. They know to keep everyone around her safe, and it gives her an environment for even just an hour a week where she feels like herself and safe. The clinic is not a convenience, it's a lifeline, and today that lifeline feels like it's being ripped away from all of us. There's approximately 1,300 patients that have been discharged. Think about that. 1,500 Kentuckianas with some of the most complex disabilities in our state have been told to go somewhere else. But where? There isn't anywhere else. Not in Kentucky, not in Louisville. For many families, not even in surrounding states. Families travel here because the Lee Specialty Clinic can provide services that aren't anywhere else.
Ms. Cutter?
Yeah.
I'm sorry to interrupt. How much longer are you going to be? We've already gone
I'm
over about
done.
a minute.
I know. Okay, I'm almost done.
I'm in front of you.
I know. I've been looking for you all day. There you are. Okay.
That's all right.
I have. I've been like, where
Some people don't want to look this way, and I get it.
Okay.
No, if you don't mind, we do want to hear you. So I do have other people.
I know.
But if you could.
I'm
just-
going to go real fast.
Thank you very much. I appreciate it.
There's already a waiting list for the Lee Specialty Clinic. I was lucky enough to get my child in on a crisis. Okay, so instead of expanding a clinic that families have waited for access for years, we're shutting it down. You can't simply replace decades of expertise in caring for people with profound autism, intellectual disabilities, rare genetic conditions that no one's heard of, and severe behavioral changes. These families and adults are being abandoned, and people making these decisions have not sat in an emergency room with a terrified, non-speaking adult. They will never have to explain a rare disorder to doctors who have never heard of it, and they'll never have to choose between keeping a loved one safe and keeping the rest of their family safe. But we do, because we live this every single day. And if you've never been to Lee Specialty Clinic, seen the smiles, the bonds between the staff and the patients, and how deeply these individuals are cared for in life, this is my life, and this is all of our lives and our children's lives. And what is happening now is putting her in danger. It's putting families like mine in danger. It is putting children and vulnerable adults in jeopardy, and it's unacceptable. Our children deserve health care, our families deserve support, and Kentucky's most valuable citizens deserve better than this. We have made the calls, we've sent the emails, we've begged for help, and we are still here fighting because we won't stop. I'm asking you to listen, I'm asking you to act, and I'm asking you to put yourselves in our shoes for just 1 minute and let your heart actually feel this. Thank you.
Thank you very much. Arthur Campbell.
This is Arthur Campbell, and I am a friend of his. My name's Pam Clay Young, and Arthur has prepared a written statement that he's asked me to read. He can't talk very well because of his cerebral palsy, and he's going to tell me what to say. But if first, I have been in a hospital about 10 days, and you wouldn't believe how they treated you. But because I can't speak very well. Okay, I'll get started now and I'll talk fast. Arthur is a disability rights activist. I'm going rogue here a little bit. Arthur was part of a group that helped get the Americans with Disability Act passed. He was invited to the White House when it was signed. He also helped get the attendant care program bill in Kentucky passed, and was part of the group that got the community-based waiver program off the ground. He's also one of the smartest people I know, so probably shouldn't underestimate him. Okay, so you can look all this up if you don't believe what he is getting ready to say. All across the Commonwealth of Kentucky, in practically every county, city, and town, the majority of garbage or sanitation companies pay their employees $17 to $32 an hour, with fringe benefits besides to collect garbage from our homes and pick up, my word, poop out of the streets. If society in general, and Kentuckians in particular, are willing to pay someone from $17 to $32 an hour, literally to pick up, again, my word, poop out of the street, but the people's government and its Medicaid system are not willing to pay over $11.50 an hour to persons who assist the elderly and people with disabilities to stay in their homes and apartments and live a satisfying and productive life. What does that say about an uncaring society? What does it say about its government? What does it say about its departments and agencies? But above all, what does it say about us people with disabilities who allow our government to disrespect and treat us in this demeaning way? And he told me earlier, he's addressing this to his brothers and sisters with disabilities and the people who support them. If he had a chance to give advice to his brothers and sisters and how to go about advocating for their civil rights and also for programs and services that we need to survive and prosper, here's what he would say. First, he'd point out that well-behaved people in suits, ties, and white hats usually wind up lower on the priority list, below the priority of animal shelters, below horse parks, and below garbage collection. Then he'd quote Frederick Douglass, one of his favorite people and an advisor to President Lincoln, when he said, "There is no gain or progress without struggle." In other words, we will not get what we need and what we want without a fight and sacrifice, and that's what everyone here is doing.
Excuse me, how much longer will you be? Because we're already a minute and a half over the 3 minutes. If Mr. I don't want to cut you off, but we do have other people, and your story is very compelling. Is there anything you want to wrap up, or anything you want to say?
One thing.
Yes, ma'am. Please do.
What? Sorry.
No, that's okay.
John Lewis. He wants to also remind us all here today that one of his favorite people, John Lewis, who was almost beaten to death during the Selma Montgomery March, one of his mottos was just to get in the way and stay in the way until you get what you want and need and deserve. And if he had it his way, if Arthur had it his way, he would have all of his disabled brothers and sisters see the movie Selma several times so they can get with the program.
Thank you, Mr. Arthur, very much for coming. Thank to each one of you, and thank you, Mr. Campbell. I have Pam Marshall, Bob Hellringer, and looks like Paula Robinson. You already spoke. All right. Then Meg Bowden. And as individuals make their way up to the table, I appreciate the board's patience. I think it's important for us to hear all the people on the list, so we get a pretty good understanding of the challenges they have, but also their compassion for the clinic. So, Mr. Hellringer, you are here. If you don't mind coming up, is Meg?
Sat here in a while.
Are you Miss Marshall?
Yes.
Miss Marshall, you have the floor for 3 minutes.
Great, thanks.
You're welcome.
My name's Pam Marshall. I'm Kentucky OT Association reimbursement chair, but also a mom of 5 and a private pediatric practice owner. The OT and PT and speech you heard, the Lee Clinic, some of the mom talk about the difference that made in her child. That is what we do. We make a difference every day. And I think sometimes as providers, we hear about these cuts or we hear about these decisions, and we hear one side saying there's not enough money, another side saying there's plenty of money, but you chose to do this. And it's very confusing because we are out helping, exactly like you've heard, the disabled, the most fragile, children, babies who don't eat. Imagine, who do you come to? You come to pediatric therapists that help you. The future of spending, we've had children kicked out of school, have such severe behavior problems, and our team within 18 months able to get them back in school. Children who would not walk would be in a wheelchair for most of their life, learning to walk. And learning, major shifts in their developmental outcome and their health. So I presented earlier in February to the Senate Committee on Health of why our rates need to be looked at. We thought we were getting an increase on 10 codes. Instead, we got a surprise where our rates were held in 22. They were dropped based on that Medicare rate. So that was about a 10% cut. We just got announced in May. And then with this additional 4%. Very quickly, I want to tell you, for an hour of a speech therapist helping a young adult, a child, anyone with Medicaid, in 2014, that rate was $48.45 for an hour. Now it's going down to $44.40. Can you imagine, with all inflation, how do we keep speech therapists employed and paid for? They have a master's degree. The same behavioral health rate for that provider type would be around $90. An OT might use a CPT code 97530. That rate in 2014 was $20.87. That's going down to $20.08. So that's 12 years ago. The rate was higher. The code for two codes for PT. PT used to be about $20.01 for 97112. It's now going down to $18.94. The current rate for a PT for an hour is $67.36. Do you know they have a doctorate? How they're 1-to-1 with the child, 1-to-1. We can only bill and get reimbursed $67. There's countless articles of how physical therapy, OT, and speech save Medicaid dollars. I'm passionate about it. Commissioner Lee, you know that. We've talked. I'm so passionate about Medicaid dollars being spent in the right way. We help these families through this journey, and our part in the budget is fairly small. And I am just begging on behalf of all the therapists in this state that are helping children and adults alike, to halt or reverse that 4% cut and find a solution. As CEO, I look back at data. Data tells a story. Look back. What has happened these last 12 years? What money is being saved because these services are being utilized? But I just urge you. Thank you.
Thank you. Mr. Hill. Mr. Hellringer.
Thank you, Mr. Chairman, and ladies and gentlemen of the board. For the record, I'm Bob Hellringer. I live in Louisville. I'm here primarily as a member of the Concerned Families of Hazelwood Center. I don't have a family member at Hazelwood, but I'm a guardian for an individual that lives there and who I know has benefited over the years from the programs and treatment at the Lee Specialty Clinic. So we're here in solidarity with everyone that has come up to Frankfort to speak today and to advocate for this great cause. Some of you know that in another life, from 1980 to 2002, I sat where you did. I was a member of the House, and for almost that entire time, I was a member of the A&R Subcommittee on the Cabinet for Human Resources, is that what it was called back then. And we had a chairman of that subcommittee, the gentleman from Hardin 25. I checked his Wikipedia page last night. He passed his 89th birthday this year. And I'm talking, of course, about State Representative Jimmy Lee, who this clinic is named for. It was Jimmy Lee's inspiration, his dedication, his hard work, his legislative skill, his power of persuasion, which was enormous, that brought this clinic into reality. And they named it for him appropriately. I'm here, I guess, to speak to his legacy. This clinic was a creation of the legislative branch from start to finish. Drafted the bill, advocated for it, debated it on the floor, funded it in A&R from start to finish. This is also your legacy of the people that served before you did. And I guess I would ask, and in all humility, that you protect and advocate for that legacy. This clinic is something you can be proud of, who have followed the people that served before you, and who had put aside. It was so rewarding. We put aside all partisan differences. We had them, believe it or not, just as much as you do today out there as Republicans and Democrats. There weren't very many of us Republicans back then, but we had those debates. But I'm proud to say that in the subcommittee, there was no partisan divide. When it came to developmental disabilities and the programs and the services for those people, we only had unanimity. And I'm just so proud of the work that people like Jimmy Lee did. And so I hope that in working on this issue and finding out how you're going to resolve it, that you will remember that legacy as something that this legislative body did that stands with anything in the history of the legislative branch of Kentucky as far as what they have done in its history. So in the final analysis, all these people here, all they have is you. They have their elected representatives and senators to advocate for them, to protect them, to defend them and their interests. And so I know you'll do the right thing, because I know a lot of you, and I know you're going to do the right thing. So thank you, Mr. Chairman, for your time. God bless all of you for your service. God bless the legislative branch, the people's branch of government. God bless them. And God bless you, Jimmy Lee. Thank you.
Thank you, Mr. Hellringer.
Thank you.
Thank you, Mr. Hellringer. Appreciate your service as well, and thank you for the history lesson on
all right.
Representative Lee.
And I don't want to leave out another gentleman that helped Representative Lee. He's still here. Before he was Mr. Brinkman, he was the gentleman from Jefferson 32. He did 10 years up here and worked on all of these issues. So
Right.
God bless you, Scott.
Thank you.
An honor to serve with you.
Our last person on the comment is Megan Bowden. Hi, Megan. Well, thank you very much Megan, for coming here to give your story, and we were really anticipating just hearing from you all. And thank you very much for your patience, for hanging here for a long time. And go ahead, and you have the floor.
Thank you. I'm joined here today by my daughter June McQuaig. My sons are actually unsupervised in a different room, so if anything's broken, you can see me after this talk. We are here because we would have been the future participants at Lee Specialty Clinic. We're here because there is definitely an individual also in an overflow room that came to my home when June was just 6 months old and signed us up for the Michelle P. waiver. I had no idea that even existed. And she was an individual who has a daughter with a disability, and she didn't wait to be asked when she came to my home. She was already a social worker. She became a social worker after her daughter was diagnosed with disabilities. She still works for the state of Kentucky as an incredible advocate. And honestly, June wouldn't be here today with me without that person. That person and her daughter access Lee Specialty Clinic. June doesn't get to have a voice today to say that she's going to need these services. Now, I've learned to be my daughter's voice, and it's a lot of really hard work every single day. My daughter has quadriplegic cerebral palsy, epilepsy, she has bilateral cochlear implants, microcephaly, global developmental delay. I've become my own daughter's expert, and I'm so proud to be able to sit in a room and say that I know exactly everything, every medical diagnosis. Not every parent can sit here and say they know why their child is disabled. My daughter was disabled by a virus called cytomegalovirus. It infected me when I was pregnant with her in my first trimester, and it caused a significant amount of damage. Ever since the moment my daughter has been disabled and we became a family that identifies as a special needs family, I have worked every single day Kentucky has never had to fully support my family. I have always continued to give back as a resident of this state. I have worked at night. I've worked during the weekends, in the middle of the night for, you name it. I've had sometimes 3 jobs at one time. And there's not a single day that you cannot look at me and say that I haven't done my part to make sure that Kentucky has continued to make money off of my family. And that's what they should do. I should always want to contribute, but I also want to make sure that every single resident has the same access to all the things that they need, including those that are most vulnerable. There's no politics for my daughter and me. There's no executive versus legislative. People are asking me to take my time as a mother when I spend over 3 hours a day feeding my daughter. They're asking me to sit down and write legislators when I want to know if you all have called Bashir and asked him to hold a special session. I want to know what you all have done. I mean, my neighbor doesn't agree with my politics, and we still stand at the fence and discuss how we are so different. Her grandfather doesn't agree with my politics, and I invited him to come with us here today. And he said, I can't wait to see you in action. We didn't vote for the same people in any election that has happened in the last 6 years. But he knows that I will do anything for my daughter, and so will he, no matter what our politics are. Today shouldn't be about politics. It should be about making sure that 1,300 individuals who will cost this state more money in their medical care. My daughter will cost more money if I put her at the Home of the Innocents today. She will cost the taxpayers nearly $500,000. I haven't met a single speech therapist who's been able to feed my daughter as expertly as I can feed my daughter. But that would cost the taxpayers so much more money if I just handed her over and told somebody that I couldn't do it either. And yet, she gets to thrive. The last thing that I will say before you tell me that my time is up, I got the privilege of meeting with a family member not too long ago who is my grandmother's age. And I didn't know until I was an adult with a child with disabilities that she also had given birth years ago to a son with disabilities. And she, of course, had that son taken away from her almost immediately. He would have been my great uncle. He would have been in his 70s at this point. And, you know, she said at a certain point while he was in the home that he had to reside in his whole life, she was called when he was 8 years old and told that he was dying. And when she went to the home to see her son, what she thought was on his last moments, she held him in his arms and started to feed him. And he then started to thrive again. She got to take him home, and he got to live until he was 11 years old. And I had to hold my own aunt and tell her that she did everything right. And that is something that I never want to have to do to any other person in this room, that I never want to have to face anyone else and say, you had to make the hardest decision in the world and you had to give up your child and give them to some stranger for them to take care of, and they didn't do a very good job. I will do the best job for her. I will do a job that no one else can do. But if you give Lee Specialty Clinic that funding, they will help those parents do that great work. No one can do the jobs that these parents are doing. They are going to do that great work. But you have to fund it. You have to fund that work and give them the chance. All right, I'm done.
Meg, thank you. Meg, on behalf of the board, and also the 138 of us that represents various districts, thank you for being a parent, a loving parent, a caring parent, and you should be put on a plateau. And I think God will have a special place for you and all the family members that take care of these children.
No, I do exactly what exactly what she needs me to do.
Thank you.
Day.
And June, thank you very much for coming, June. You take care. I just want to address the family of who use Lee's specialty clinic, and those who work there as well. Playing with what you have gone through is not, and through the media, is not right. And I want to let you know that Senator Adams and I care about you. We care about your families, and we care for those who are least among us. Some of y'all might know I ran a nonprofit mental health center and witnessed firsthand the struggles and challenges that individuals and families that go through, not only emotional, but financial and spiritual stress and strains. So I want to let you know that we are with you. We understand. We have not gone through your shoes, but we are there with you, beside you, behind you, and do what we can to be in front of you and know where to help you out. Let me also be perfectly clear. The operating contract for Lee Specialty Clinic to provide services has been eliminated by the administration. The services are still required covered benefits under the Kentucky Medicaid program, and the General Assembly increased funding of these Medicaid benefits in the budget. What we have not heard, if there is a plan to continue to provide access to these services from the administration. So I ask the question to you, to ask the question of the administration, what is their plan? Thank you for joining us. Thank you for letting us know.
Mr. Chair,
what's
thank
going
you
on.
for the opportunity.
We have concluded. I've concluded the agenda.
I respectfully
for the
ask for the opportunity to comment.
This is not political. This is real.
Thank you, Mr. Chair.
Dr. Stack, you have made political statements. You have blamed the General Assembly. The governor has gone through the process. Y'all have made your position known, quite known, of what you're all trying to go through. So with that, Dr.
Sorry,
Stack.
I'm being silenced. I'll stand down, Mr. Chair.
Thank you very much. I appreciate it.
We haven't heard his statement. Let him make his statement.
Right. Let the people hear it.
3 minutes.
3 minutes. Let the people hear it.
Mr. Stack, you have 3 minutes.
Thank you, Mr. Chair. What I had intended to say was I don't believe for a minute that members of the General Assembly or the executive branch intended to make the families and their loved ones political pawns in any game. I think that choices and decisions have consequences. Budgetary decisions have to be made. When there are consequences, they don't make sense to the masses. I'm an emergency doc. Some of you who talked about what it is like to care for folks and the very real challenges you face. I didn't walk in your shoes, but for nearly 25 years, I tried to care for people in settings that were not well suited to the needs you have. Lee Clinic is special, and the people who care for you are all special. The budget that was passed did not contain enough resources to do all the things the cabinet does. I don't want to argue with the legislature in this venue. That is where we stand. I have to be able to have the dollars to pay the bills, and I'm engaged in dialogue and look forward to ongoing dialogue with the legislature. The governor, I hope, will be able to announce tomorrow a Band-Aid patch to help the Lee Clinic through this next year. Your advocacy today is important. I'm very glad to hear members of the legislature voice support for the Lee Clinic and for you. Your advocacy will need to continue. I expect for you to hold us in the executive branch and the legislative branch both accountable. None of you are pawns. There's 4.6 million people in this Commonwealth, and the vision of the cabinet is that every Kentuckian reaches their full human potential and every community thrives. This complexity is something we have to work through between the branches of government. You shouldn't be subject to this, and we'll continue to work in good faith. So thank you for being here. Thank you for the opportunity to comment, and thank you, Mr. Chair, for the opportunity to make these remarks.
You're welcome, Dr. Stack. And I'm happy to hear that there is a fix on the way, and the fix is basically just renewing the contract that you already have. That the money is there in order to do that. So thank you all very much for coming here today. And with that, we stand adjourned.